All right, hi everybody. It's Tuesday, April 7th. We're going to do this brief update on COVID-19 by recording, as I anticipate this will be a much shorter discussion. But today we wanted to focus on a select topic about this the question that is currently coming up regarding blood pressure medication in the context of COVID. We are talking about the information that is coming, that a lot of people are getting online right now, seeing online, reading about, hearing from other people about certain blood pressure medications that are called ACE inhibitors and angiotensin receptor blockers. People are reading that some people, there are some suggestions being made to be off of either or both medications. There are suggestions to change medications from one to the other, etc. And so what is this all about? I'm going to take the moment here just to explain that to you from my interpretation of the data. And it's not just my interpretation alone, it's the viewpoint that I subscribe to, that I have spent much more time digging out for my own personal understanding and to be sure that I am fully confident about that line of thinking and decision making. Indeed, I can say that I've been questioned, understandably and justifiably and respectfully challenged and questioned and challenged about this topic several times in the last half week to week. You know who you are out there who might be seeing this, and I appreciate those questions because in my own digging, I realized it is worth affirming for myself that I understand what I am subscribing to, and I revisited a lot of basic science and developed more questions on top, but in the end, I was able to answer them from my personal satisfaction and felt even more convicted about the decisions and conclusions I came up with that many other people have already subscribed to in recent times. So let's just dig into it real quickly here. So critical thinking at a critical time. This is just one of the premier research articles that has driven this topic in question. Are patients with hypertension and diabetes at increased risk for COVID-19. This is from March 11th, as you see, a highly respected journal called The Lancet. They basically presented and proposed that a great number of COVID patients have an elevated enzyme called ACE2, ACE2. And this is important because it is well understood now that COVID-19 as a virus enters and activates its pathology and infectivity in our body through that enzyme. And so the question here is, in retrospect, looking at COVID-19 patients, are those patients who have a high amount of ACE2 enzyme more at risk of developing this infection because they're facilitating the infection rate of transmission within the body and progression of disease. Their further argument within this study is that it is known that diabetes increases or upregulates, is the medical term we use, upregulates this ACE2 enzyme, but they also proposed that these ACE inhibitor medications and ARB medications also upregulate the ACE2 enzyme, and that common denominator is perhaps why a lot of these patients are seen to be suffering from a greater morbidity and infection rate or even mortality from COVID-19. So as you see here, this is the sort of the summary part of their paper, but as I kind of summarize for you in the bottom here, bottom right, these ACE2, the enzyme increasing drugs like ACE inhibitors and ARB medications are at higher risk for severe COVID-19 infection and also the diabetes, as it also increases that enzyme. Okay, so what are the medications we're talking about? So here's examples of the ACE inhibitors on the left. I've underlined and italicized that lisinopril is by far and away, in our area, our practice, certainly the most common ACE inhibitor. On the right column, these angiotensin receptor blockers I put question marks along the top three because I don't know that I've ever seen any patient on those three. The middle one of those three question marks is more likely, but I don't know that I've personally had patients on that. Losartan is the most common ARB medication by far and away from my experience in our area, certainly our practice. So if anyone's on these medications right now, this talk pertains to you in particular. All right, so I've wanted to show you a little more graphic illustration about what we're talking about. So as you can see, this bottom half here, this is the cell membrane, this blue line. So this is all inside the cell. Angiotensinogen is a compound that's floating around in the blood. It gets converted by this enzyme called renin into this AT1. AT1 is converted into this very important topic we're going to refer to recurrently in this talk called AT2. It is converted into into AT2 by this enzyme called ACE1. I know the terms are all very similar, so it's hard to keep track. So bear with me. Most importantly here, though, AT2, as you see, is then converted into AT2 is then converted by this very important enzyme called ACE2 into this further compound here that we'll just call AT1 through 7. All right, so let's keep it the simple model here. This is the simple side. What I've always told patients in my practice is picture a plug and an outlet, the plug and outlet model. What we've done with ACE inhibitors, which are the left-hand column of those medications in the previous slide, is this. We are blocking, as you see on the bottom half of this, this illustration, where it says ACE2, ACE1, those medications are impacting the ACE1 enzyme. And so you're blocking the production of AT1 into AT2. On the other hand, and so in the illustration that I have with patients in the office, it's like covering the plug. So the plug cannot go in the socket. And we're trying to disrupt that connection to lower people's blood pressure. On the other hand, the ARB medications are used to plug the socket. Okay, so we're still disrupting the process. We're just affecting the other side of the process. And you'll see in this illustration, so it's not as simple, quite as simple as the plug and outlet, because while we may be able to use the former medication, the ACE inhibitors, to block ACE1, we're not necessarily blocking the plug through that receptor called AT1R. You'll see that AT2, I didn't quite clarify that. You'll see that AT2 can convert into the AT1 through 7, or it can act on this receptor called AT1R, the blue pentagon. And you'll see that the AT1R is a protein on the cell membrane, and inside the cell, it leads to inflammatory processes. It's pro-inflammatory. Pro-apoptosis means it leads to cell death. Pro-fibrosis, it leads to scarring. So all bad things, negative outcomes. Whereas if AT2 is converted by this ACE2 inhibitor, this circle on the right side, it converts into this AT1 through 7 compound, which are all good things: anti-inflammatory, anti-apoptosis, meaning it's against cell death, technically translated, and anti-fibrotic. It does not produce scarring potential. Perhaps it's reverse. So the ARB medications, they don't plug the socket in terms of the receptor. They're not actually, I'm sorry, they are plugging the socket with AT1R. As you see in the lower graph, the ARB medications are blocking that receptor. But there's actually there's a step in between. There is this matter of this ACE2 enzyme, and I don't talk about that when I illustrate this to patients in the office in a verbal setting, but this ACE2 enzyme is the key of focus in the studies that are being discussed and being translated into the media about, or social media or internet, about trying to be careful about these medications. Because in that first paper, as we said, the question is, do these medications really upregulate or increase the amount of ACE2 enzyme? And as you see in the lower graph, in that red circle, the SARS-CoV-2, which is the COVID-19, that virus attaches to ACE2. So this graph, this illustration comes directly from a research paper, except for those red arrows that I've added there. This comes from a research paper explaining the model. Okay, so the questions I derived from this really are, how much do the ACE inhibitors and ARB medications really increase ACE2? And if we leave ACE2 around, okay, will that really facilitate COVID-19? The presumption is yes, but how much do we know that to be the case? And if we only use an ACE inhibitor to block that left circle in the top left diagram or bottom right diagram, the left circle, if we only use an ACE inhibitor to block the ACE1 enzyme, will that AT2 in the square, will that really prefer one receptor over another? What I mean is, will it really prefer the AT1R receptor, which goes into negative effects, versus converting into AT1 through 7? Okay, so now this is a more complicated version of that graph I just showed you. In fact, I started asking myself as I'm digging through this, do we really know that the AT2, again, AT2, this doesn't have the shape, so it's not as easy to understand, but you'll see in the green circle here, angiotensin 2 in the circle, that is equivalent to the square you see in here that's marked as AT2. AT2 is angiotensin 2. Do we really know, look, how much does AT2 really convert into various endpoints? You'll see in the green circle, the AT2, it converts on the left side down into this AT2 receptor. It can convert into this pink box down below, AT4. It can convert, it can act on AT1. It can act on this other mechanism through MRG2, MRGD, as well as this MAS. Wow, it's complicated. There's 5 different pathways it can actually go down the road with. So I ask myself, well, as you see the top yellow circle, all right, there's the ACE inhibitors medication again. They can block the ACE1 enzyme and block the production of AT2 and therefore reduce all these 5 pathways. Or we could use the ARB medications, the lower yellow circle, and block just the AT1 receptor. So then I ask myself, well, how big a deal is it really just to block the AT1 receptor when you've got these other 4 areas that it can go to? Is there really benefit in just blocking the AT1 receptor? That's part of the question. So as you can see here through this at the bottom, you'll see that the 2 pink squares are listed as having some inflammatory properties, right? And so AT1 again is a bad outcome. It's pro-inflammatory, it's pro-fibrotic. Vasoconstriction means the blood vessels get tighter, so that's what leads to high blood pressure. AT4, interestingly, if you look at the bottom, it says it is inflammatory and pro-fibrotic, but interestingly, AT4 has a vasodilation, so it widens the blood vessels. So AT4 is not a problem in terms of high blood pressure. Whereas if you look at the other 3 green squares, these are all beneficial pathways: anti-inflammation, anti-fibrotic, antioxidation, vasodilation, widening of blood vessels, all good things. So at least we've answered some of those questions. I just wanted to show you that this whole story is quite complicated, and this is just a very small tip of the iceberg of what goes on in the body on multiple levels, multiple pathways. Okay, so here's another study that comes out, again, the same journal, The Lancet, a specific form of subset of The Lancet called Respiratory Medicine, March 26th. So hold on a second. This gentleman, who actually this was more of a correspondence article. It wasn't so much a study, but they refer to that first journal article from March 11th in the same journal, and they say, hold your horses for a second here. So what do these guys have to say? Check this out. Angiotensin 2, AT2, primarily activates the type 1 receptor, the AT1R, which was that hexagon in that first graph. So their answers our first question. AT2 definitely is going to prefer that receptor, which we don't want activated. All right, and as they say, which potentially mediates pulmonary inflammation, fibrosis, i.e. scarring, and edema, swelling, okay? ACE2 activation, now we're talking about that enzyme, the enzyme that COVID-19 acts on. ACE2 activation results in low amounts of AT2. So this is something key. We currently, in the literature, it is clear that when ACE2 enzyme is activated, there is a decreased amount of AT2 because, as you'll see back here, when you have have the right circle in the top graph here, the right circle, when it is using AT2, when it's activating AT2, you're going to get less AT2 to actually act on that hexagon blue receptor, right? Okay, so when ACE2 activation results in lower amounts of AT2, you get less activation on that receptor, and you actually get more of that angiotensin 1 through 7, which we said was a good thing. Okay, so lesser impaired ACE2 activity, less of that ACE2 enzyme, results in excessive amounts. Impaired ACE2 activity, so meaning if you don't have proper ACE2 enzyme functionality, then you're going to have excess AT2, right? If the red circle if there's not enough of it around, you're going to get higher amounts of the square, the AT2, and therefore, since we already stated it's going to prefer the blue hexagon receptor, AT1R, you're going to get bad things happening at a higher amount. Again, impaired activity results in excessive amounts of AT2, allowing for unopposed activation of the receptor and subsequent development of acute respiratory distress syndrome. All right, so we've answered at least one of those questions there, if not two. Moving on, the same paper, these guys are piling it on here. Look at this, the first circle. These guys in this other study found that mice treated with losartan, we're talking about specifically the angiotensin receptor blocker medication, after inducing acute lung injury using COVID-19 spike protein. So it may not be COVID-19, but it's the original form of SARS from years ago. A spike protein very similar to COVID-19. Using losartan in mice who had lung injury from a COVID-19-like infection had significantly diminished lung injury and pulmonary edema, i.e. swelling, compared with mice treated with placebo. So again, losartan here improved lung injury. Furthermore, second circle here, furthermore, recombinant human ACE2 infusions, so not to be confused, they're giving human infusions of human enzyme, ACE2 enzyme now, okay? They're giving more ACE2 enzyme, that circle, or giving losartan, both prevented severe lung injury and pulmonary swelling in mice that did not have that ACE2 enzyme, all right? So giving losartan, the real key here is giving losartan, again, prevented severe lung injury and swelling in mice that didn't even have the ACE2 enzyme. Third, at the bottom, treatment of mice after infection with this specific influenza so it's not COVID, granted, or COVID-19, with losartan, again, the findings were reduced pulmonary swelling, lung white blood cell infiltration, that's neutrophil infiltration, so signs of infection and inflammation, and significantly improved survival. So we've got three pieces of data that this author comes back to and says, hold on a second here, there's evidence suggesting that the ARBs can be good, all right, through this exact mechanism that we're referring to. All right, let's go to an even newer article here. This is New England Journal of Medicine, March 30th. So this is really hot off the press. They're making even more complicated, or they're actually asking a question that at least complicates the story. Is it that we actually want more ACE2 enzyme? Remember, initially the question was, are patients who have more ACE2 enzymes at more risk because the COVID-19 virus is attaching to that enzyme and causing damage? And therefore, diabetics are more at risk, and people who arguably might be on these medications are at more risk because there's more ACE2. These guys are saying, hey, we may want more ACE2, and in fact, they're suggesting, as the title suggests, there's potential for benefit rather than harm of blocking these, using these blockers, these medications in COVID-19. So the key, as I put here, is the key wrap home on this paper is, for context, is when we have ACE2 dysregulation, it appears that there's some problems. Okay, when there's low ACE2 enzyme, let's go back to that graph. There's not enough of that the red circle on the right. We know there's problems because you get more of that square AT2, and more of that is going to act on that blue hexagon circle. We know that. At the same time, when we have low amounts of ACE2, it's also a problem. So whether it's a low amount or it's not working properly, we have problems. So we want, that's the point of this paper, is we may want more ACE2, even though it intuitively seems that that's where the virus is acting through. So these guys are making a comment near the end of their paper saying, giving ACE2 protein, so I talked about that in the middle circle from the previous Lancet journal, they're also pointing out that giving this ACE2 protein may be beneficial, and back to what they're writing exactly here word for word, in restoring the balance to the network and potentially preventing organ injury. In addition, paired trials of losartan, the ARB, as a treatment specifically for COVID-19 here are being conducted among patients who have not previously received treatment with some kind of, when they say RAAS inhibitor, they're talking about the collection of medications that impact this whole dynamic process that I've shown you in the graphs, and are either hospitalized or not hospitalized. So there's a study ongoing right now that giving ARB medications, the losartan type medications, may be beneficial, enough that it's being studied actively right now. Or they're saying give more of the ACE2 enzyme. So they're looking at this in a couple different ways, but you'll see that if you notice the absence of what we're not hearing here is some comment about the ACE inhibitor medications. All right, there's a sort of void of that discussion. So here's the, wrapping this up here, this is the current recommendation algorithm, at least from one authoritative academy or clinical practice guideline. They're saying, based on the information that has been accumulated to date, any patient taking an ACE inhibitor medication or an ARB medication, at the top there, right? You have two columns. If you, basically for any of these patients, if you, on the left column, you got patients who are newly on these medications for some kind of uncontrolled problem, whether it's blood pressure or heart failure. The right column are people who are on it strictly just for blood pressure control. The blood pressure is in good standing. They've been on it for a while, et cetera, et cetera. The far majority of people taking these medications right now are going to be in the right column category, all right? So looking across from row to row here, the top row is people don't have COVID-19. The recommendation right now is, by these folks, continue what you're taking. There's no reason to change. If, however, on the very far right side, you have a high risk of coronavirus infection, they are suggesting considering stopping either medication that you're on, ACE inhibitor or ARB. If, in the second row, you become positive for COVID-19, they're suggesting you, again, in the left column, if you just recently are on it, you just continue the medication. In the right column, if you've just been on these medications for a long time for other stable, well-controlled situations, they're suggesting you stop it. And then in the bottom row, once a person's recovered from COVID-19, they can resume the medications as before. My suggestion from interpretation of the data, and I believe, as I'll wind up here in the next slide or two, the argument, in my opinion, the perspective that I subscribe to is completely different. We are, from the data that I'm seeing, the suggestion here is, if you don't have COVID-19 yet, if you're in the right-hand column and you're taking the ACE inhibitors or ARB medications, and you're well controlled and it's just a stable, consistent medication usage, the data to me suggests you change the ACE inhibitor over to an ARB before the infection. And if you are positive for COVID-19, I would agree at this point, given lack of other information, lack of other data, it is prudent to leave it as is. Yeah, prudent to leave it as is. It might be too late to change because there's some question of whether changing the medication at the last second might disrupt what we call homeostasis or balance of what is happening. We just don't have information there, so I think it's fair and prudent to leave as is. But I would not stop the medications per se, certainly, especially if you're on an ARB. I would not, as the original guidelines say, stop taking the medications. And of course, if you're recovered, then certainly continuing and resuming the medications is fine. I put that question mark in the top left because if a person is uncontrolled and recently on the medications for whether blood pressure, heart failure, or whatnot, and they don't have COVID-19, I'm not sure what to make there. I don't know that I would necessarily just suggest to someone change over to an ARB. There could be reasons why an ACE inhibitor is preferred over the ARB in those conditions, and there's too many factors and variables there for a case-by-case, a need for case-by-case assessment. So I would strongly hesitate to make some kind of sweeping recommendation or suggestion to patients that I would care for in that category. Let's see if I can, okay, so here are the take-home points. Kind of summarizing this again, I've put that slide, the graph back up in the top right again, so we can kind of refer to it here, because I know I've jumped around from side to side, and again, the terminology I understand is difficult, but let me try to summarize this and make it clear. I would agree with the current recommendation. Do not stop what you're on if you're acutely infected. But that's why we're having this conversation for the majority of folks who aren't infected at this point. The topic is, do we make these changes in people who aren't yet infected? All right, we're trying to make some preventative changes ahead of time. It says number 1 again, should be number 2. But here, nonetheless, COVID-19 and the ACE2 enzyme. Again, we're talking about this red circle here. We know COVID-2 attaches to this enzyme, and there's a question of whether this enzyme is upregulated or increased in volume as a result of the ACE inhibitors and ARB medications. We know COVID-19 attaches that enzyme to infect cells. We know that when ACE2 is activated, it turns down ACE2 volume, and that is bad. That is fact. We don't want ACE2, this enzyme, to be lesser. If there's less of this, there's more of the AT2, and more AT2 is going to lead to this hexagon, and it's going to be bad. And that's what we comment here. Statement 2, we know AT2 will preferentially attach to AT1R, this hexagon. We know it will prefer that over the other receptors I showed you in that more complicated slide. And that is bad. That is fact. We know that ARB medications will block the AT1 receptor. We know, as shown here, the ARB medications will block this receptor, and that is good. That is fact, because this is the receptor I showed you in that complicated slide. This is the one receptor we don't want activated, because all outcomes from there are bad. Excess AT2 here, due to being unchecked, due to a dysfunctional or lesser amount of this ACE2, whether it's due to COVID or any other reason, will lead to greater activation of this enzyme, because there will be more of this AT2 activating there, and that is bad. Okay, in this case, we're saying it's logical. It's expected, it's presumed that if there is less ACE2 due to this virus, that the AT2 will preferentially impact that receptor. We know this will happen in general. We assume that if the ACE2 is dysfunctional because of the virus or turned down, that the same model will apply. That seems logical, even if it hasn't been shown outright in randomized, double-blinded, placebo-controlled trials, all right, which is the gold standard of studies. Lastly, ACE inhibitors, those medications like the lisinopril class, as shown here, we know they have no impact on the receptor, leaving that receptor vulnerable to AT2 activation, that square, it leaves it vulnerable. Whether that's because of the absence of functional amounts of this enzyme or insufficient amounts of it due to COVID or otherwise, we assume that is bad. Okay, objectively, scientifically, we cannot say we know that for a fact. We've not studied that with a double-blinded placebo randomized controlled trial, but it is logical. It seems fact by what's called in math the transitive property. If A equals B and B equals C, then the transitive property is A equals C. All right, and that's ultimately a perfect epitome example of what we call translational medicine. We may not have studied it out exactly, but it is reasonable and it is logical. It makes sense. Further take-home points. The literature focus so far has been on this enzyme, the ACE2. Again, the original study that I pointed to in this slide set, they're arguing that diabetes is known to increase ACE2, and they're suggesting that the ACE inhibitors and ARB medications also increase ACE2, and they're suggesting that's bad. The focus has been on this ACE2, but in the big picture, the receptor, AT1R receptor, this hexagon, to me, that's arguably of equal concern. We know that COVID-19 acts on the enzyme, but do we really know how much damage is due to the AT1R receptor? We know that the virus is doing its damage largely through that enzyme, but are we maybe not putting as much focus on the effects from the receptor, assuming that that is part of the picture, again, by transitive property, as we mentioned in the previous slide. The next question is, do these medications really upregulate the ACE2 enzyme? The New England Journal paper I pointed out in this slide that I didn't talk about in detail earlier, but they make several arguments that the proposal by the original Lancet journal authors that these medications upregulate or increase the ACE2 volume is not necessarily true. So a little minutia there I didn't think was that terribly time-worthy, but there is debate as to whether those medications even upregulate ACE2. But ultimately, I ask, does it really matter? Again, right, because if ACE2 is, if that enzyme is upregulated or not, there's debate as to whether we care if it's upregulated. In fact, we may want it upregulated, as they already, in the New England Journal articles, authors point out. So again, presumably leaving this ACE2 unchecked, meaning if we can't impact ACE2, okay, because everything we've talked about here has to do with whether having enough of it or too much of it is bad, and ultimately I'm suggesting what about the impact on the AT1 receptor, but nothing we've said here is arguing that there's a way to prevent the COVID-19 from attaching to the ACE2. We've not talked about a way to prevent this from happening. So presumably leaving that unchecked and vulnerable to the virus is bad, but ultimately we don't have an action point for that right now. So it is what it is. So let's focus on the other targets we do know about, right? We may not be able to avoid that, that ACE2 enzyme and virus connection and activation, but let's focus on targets we do know about. And as our previous seminar was about, in more detail, number one, avoidance and prevention through contact precautions, the distancing and sheltering. Number two, the viral contraction. Can we halt progression through the mucosal adhesion when the virus is in our nose and our mouth, through things that we talked about like propolis, that initial attachment of the virus into our body? Can we halt progression there? Number three, if it's already gotten past that point, can we reduce or improve the initial defense against that viral attack by improving immune support prior to the infection and boosting the immune system? Number four, can we stop the progression of the viral infection? Can we stop that furin spike protein we hear about all the time from being broken and activating the whole cascade? And then five, can we reduce, if we've gone past 1 through 4 and the virus is into our cells and our bodies infecting and replicating, can we reduce the hyperinflammation response through that NLRP3 inflammasome we talked about before in the last talk, as well as the cytokine storm overreaction? Can we stop that overreactivity that's leading to a lot of morbidity and mortality? So rewind here. As I said in the 2 slides before, I think it was, there are some considerations and exceptions. Nothing in medicine to me is rarely, at least very rarely, is there an absolute universal application to everybody. As I said in that in the slide here in the top left, patients who are newly on these medications, or there's some other reason they may be on an ACE inhibitor, for specifically, there may be a reason for it. They may want to, they may warrant staying on the ACE inhibitor and not changing to an ARB. Okay. We will learn more. This is all likely to change, or at least be amended. This stuff is changing on a weekly basis, sometimes daily. But my argument is this: the cumulative data heavily argues for the angiotensin receptor blockers, and the current studies and the commentary all focus on the angiotensin receptor blockers. All right, as I said before, there's no commentary about studies. I've not seen any commentary about studies suggesting that the ACE inhibitors may be of benefit to either reduce inflammation or reduce viral progression, or reduce some bad outcomes, negative outcomes in the context of COVID, all right? As I said in the graph, the ACE inhibitors, regardless of whether they impact the enzyme or not, they do nothing with the receptor. They do nothing for the virus infection. There's no real benefit that I can see in the data or just intuitively from the science known of how the ACE inhibitors will help us in COVID. The ARBs, on the other hand, we see how mechanistically they can benefit by blocking that receptor that leads to damage. And so even if it can't fight the infection, it can hopefully protect us from further damage. And furthermore, to me, it is reflected, that argument is reflected in the fact that there are studies ongoing right now, actively ongoing, looking at that exact question. And there are studies in the recent past, even if not with COVID-19, at least with what we might call COVID-1, the SARS from years ago, where they showed benefit with these medications, ARBs, in blocking that receptor to reduce pulmonary swelling, pulmonary fluid, death rates, lung injury, et cetera, et cetera. And so then one might ask, what about all these guidelines from the academies, the other authorities? You know, major academies have come out and said, don't make changes in medications. It's okay, it doesn't matter. I'm not here to say that myself or those who subscribe to the similar perspectives, that these minority voices are absolutely right, okay? I'm not even trying to say that. But I will point out that it is worth understanding that these large academies and authority entities, rightfully so, they need to see robust and replicated data over and over to be able to make broad sweeping statements. If they made statements as a governing authority on small bits of data over time, their authority position is undermined greatly because they could be blown by the wind every couple of months. So understandably, there is a lag time before these governing authorities are going to make stronger sweeping statements, as we kind of discussed in the previous webinar already with regard to like hydroxychloroquine and Zithromax. It was only days after that last presentation when we were commenting that, you know, the data is pretty darn strong on that combination, and yet it's not FDA approved. And I think within 2 or 3 days of that presentation we gave, it was indeed FDA approved. You know, they hadn't completed randomized double-blinded controlled trials on that combination in 3 days by any means. It was a matter of, hey, it looks to be effective enough, and in this time, in this critical time, when time is of the essence, the benefit to risk ratio is high enough in our favor, it is worth going ahead, okay? And so this is the crux, is that when we're talking about translational medicine, when the benefit to risk ratio is high enough and the safety profile is low enough, the rationale is there, it makes logistical sense, there is room for argument to consider other approaches that might be more forward thinking, might be more progressive, but nonetheless are different than the standard practice guidelines that might be touted by governing authorities at that moment. You know, ultimately, this is a commentary on the translational medicine of a good friend, Brett. You know who you are out there. We had an interesting conversation a few months ago where he was making the kind of provocative, exploring this topic with a provocative question of, you know, with the internet out there, who's an expert anymore? There's so much information out on the internet. There's so many things people learn by watching YouTube. You know, it's unbelievable the kind of information we have access to. And so he was making the argument, I mean, is anybody really an expert anymore? Or what is the definition of being an expert? And I thought it was really intelligent and insightful when he was arguing that, you know, with the internet, it's changed the playing field. When, you know, especially at least in the context of medicine, patients are so much more educated now than they used to be, more informed at least. Let's say more informed at the least. And so perhaps one conclusion that he came up with that we were discussing is perhaps an expert these days is better defined as one who understands the scope of information enough and has enough um, practice and familiarity and experience with the topics at hand to be able to navigate and interpret all this massive amount of information that we all have at our hands. You know, in medicine, maybe years ago, decades ago or whatever, you know, patients, we didn't have that information. And so now that we have the information, it's a different dynamic, but interpreting and navigating the info is heavily on the clinician side of responsibility, making sense of the information. It's very critical. And again, in this critical time, in this COVID era, the critical thinking, but yet in a necessary and a very rapid pace, because time is of the essence and the data is coming out in pockets and in less uniform, cohesive manner than is usually the case. It becomes all the more crucial. So I put here translational medicine. What is it about? It's about bridging the gap. It's about applying the gap between studies and ultimately guideline practice application recommendations. Bridging the gap and applying sound critical thinking as best as we can, and currently, as I said, as quickly as we can, because it's a very critical time. The benefit to risk ratio is very important, but ultimately, especially in regards to this ACE inhibitor ARB medication issue, making the change from an ACE inhibitor to an ARB medication is extremely common. Doctors have done this all the time, day in, day out, year in, year out for years. And especially where we're talking about this being on a temporary time change even, let's say for 3 or 4 months, or at the most, perhaps, in this crucial COVID crisis period, to me, pragmatically, it almost feels like overanalysis, especially in the context of what I presented here. The argument seems overwhelming to me. Again, this is my personal viewpoint. We've talked about this as a practice. I'm not saying that myself or anybody else who agrees with this perspective is the end-all be-all, but it just makes sense. And again, if I'm a patient who's taking an ACE inhibitor, from what I know, I am absolutely not wanting to take that. I'm absolutely going to be asking to change to an ARB. So there you have it. This is the that is the more detailed explanation of why I, as a practitioner, and I believe in our practice, we are on the same page with making this recommendation to our patients. If you are seeing this presentation, you're not part of our practice, by all means, this is not intended to be medical advice for those we are not caring for. Please talk to your doctors about this question if this is concerning to you. But certainly, at least for the public at large, and certainly at least for our patients, we want to explain in better detail why this conclusion has been made and why there's such discrepancy currently, at least, with the governing practice recommendations that are also available to us and known through internet and other resources. Just as a brief update on the public health level side of things, epidemiology, it seems that we are, in my perspective anyway, I know Jessica's not here to present that information in more detail, but I'm holding great optimism in what is happening. There's a lot of talk right now about the peaks, the surge and peak that we may be experiencing in hotspots, and especially around the country in the next week to 10 days. That as on a federal level, there's been commentary that we're going to experience great suffering and great number of deaths in this next week. A lot of gloomy news coming forward and forecast for sure. But at least in our local area, the numbers that we're seeing climb, which are expected, but nonetheless in Boston, Beverly, and especially locally to here in Newburyport area with Anna Jakes, the climb of those numbers, the rate of climb has been not that impressive to me, thankfully. There could be argument as to, you know, whether hopefully down the road we can look back and say, hey, we'd already kind of been hitting a bit of a peak already, perhaps. I'm hopeful that if we do experience a surge in our local area in the coming week to week and a half, that it will be drastically lower than we have been predicting and preparing for. But nonetheless, the preparations are absolutely warranted, and thankfully, all the local health officials and healthcare authorities and systems and entities are doing their job to prepare for the worst. Not to create inappropriate expectations or hopes, but certainly the news in the last 24 hours or so out of New York City is similar in that they have seen a lack of climb in their number of deaths. Granted, they, or even I believe even hospitalizations from COVID-19. I believe the qualifier on that is that those last few days do include the weekend, and sometimes the reporting on the weekend is a little bit lagging. But there are some signs, initial signs of hope, and so I'm holding on to that hope, certainly for our local areas. I'm hopeful that Boston will not develop that tremendous surge of what is occurring in New Orleans, Detroit, and New York City. Reports of which a number of colleagues and I have been discussing in the last half week in hearing about and reading about what some of the firsthand experiences are like in the ERs and ICUs. It is absolutely horrifying. It is beyond comprehension. I find myself completely having reestablished a new level, a new bar of what is surreal. Reading through that I'm still processing that, and often find myself speechless. So fingers crossed and Godspeed that does not, we do not experience that here in the Boston area. And peace and prayers to all those in those other areas of the country that are going through that horrific experience. On a personal level, just to bring it home, I was connected with my cousin in Long Island over the weekend regarding a family member, and have been trying to help my family member from afar, and unfortunately that was not successful, and we have experienced our own extended family anyway, but firsthand experience loss with COVID-19, and so yeah, we on an outpatient level, we have run the gamut through our practice with patients, family members, and certainly I'm aware of friends in our local area who have also lost extended family loved ones to COVID-19 as well. And so with all that in context and backdrop, that is why in our practice, our colleagues who we are working and networking together with this topic, we are still working 110, 120 plus %, trying to better understand and keep up to date with this massive amount of information. Because if we can understand what is and keep up to date with what is happening on the inpatient intensivist side of things, the ICUs, and understand the pathology and the science behind it, perhaps we can better understand, even if it's not out in guidelines yet, in these authoritative commentaries and opinions, perhaps we can better come up with some better cutting edge interventions to reduce people's risks should they contract COVID, to either reduce the risk of becoming infected at all and allowing the immune system to do its job and prevent even symptomatic COVID, or stop the progression of COVID from the nasopharyngeal, oropharyngeal pathways into the lungs, or stop the greater replication of the virus in the cells, or stop the hyperinflammation response. Those are all these different targets, each one of those areas having specific scientific targets. That is our goal, and we are still researching this and working pedal to the metal, trying to understand this for everyone's behalf, doing our best in this historic and unprecedented time. With that, I'm going to end that today, and peace and safety to everybody, and we will bring further updates as they come along, whether it's from learned information or epidemiologic perspectives. All right, we'll call that an end, and best to everybody.